It would be one worth noting and talking about later for sure.
Yeah.
You are correct.
We still have a few minutes, Dr. Nizio.
Not a problem.
We decided to use just a regular Zoom meeting this time instead of a webinar. So
Yes, ma'am.
Morning to everyone. I know we have a couple more people that have come on. I don't know if we're going to start. I'm assuming we're just going to start at 12 exactly.
Yeah, I might give Dr. Degenhart one more minute.
Probably a good idea.
But then
Not sure if he's seeing patients this morning or not.
Then I'll introduce you, Dr. Nizio, and then I'll let you have the floor.
Okay, great.
Mm-hmm. All right, good morning, everyone. Thank you for joining us. My name is Sarah Aminurad, and I am the PBRN coordinator for DO-Touch.NET. Give me 1 second. Okay, there we go. All right, so before we get started, we just have some housekeeping items to go over before we let Dr. Nizio start with her presentation. So if you have registered for CME credit, I need you to add your name to the chat to verify your attendance for CME. If you received this morning your physician attestation form, and you'll receive your evaluation this afternoon, and you need to complete both of those in order to receive CME credit. If you have any technical issues during this webinar, please send a message in the chat and one of our team will assist you. If you have any questions or comments during the presentation, please feel free to type them into the chat. And also we will address them, Dr. Nizio will address them, and also you guys can feel free to address them as well in the chat. After the presentation, we will have some time for discussion and questions. If you would like to speak during the discussion, please raise your hand and we will unmute your microphone, as I have all of you muted automatically anyway. We ask that you briefly introduce yourself and feel free to turn on your camera if you would like to. When contributing to the discussion, please limit the microphone time to 3 minutes to allow time for everyone who wants to participate in the discussion, and we will provide you notifications using flashcards to assist you in keeping track of time. After everyone has had the opportunity to make comments or questions, there may be additional time for further discussion. Please keep in mind that this webinar is being recorded and will be placed on the DO-Touch.NET website, where you have the opportunity to continue the discussion, and I will send you an email when that is available online. Please note that DO-Touch.NET has no financial disclosures to convey. So now please help us welcome Dr. Jessica Nizio, who will present the journal article, The Global Summit on the Efficacy and Effectiveness of Spinal Manipulative Therapy for the Prevention and Treatment of Non-Musculoskeletal Disorders, a Systematic Review of the Literature. Dr. Nizio is a current resident with the Osteopathic Neuromuscular Medicine Residency with Northeast Regional Medical Center here in Kirksville, Missouri. She also has an extensive background in family medicine research and as a teaching assistant and assistant professor. Dr. Nizio, the floor is yours.
Okay. Hi, everyone. So is there a way I can bring up the PowerPoint? Share screen? Can I share my screen?
Yes.
Yes. Okay. Okay.
And we are seeing that, ma'am.
Okay, perfect. Thank you. So, and I'm not sure if I'm going to be able to see the chat. So if someone can keep an eye on the chat questions, if possible,
Yep, we will absolutely do that.
Great, thank you. So again, thank you again for having me come and do this. I am excited to be able to talk to you guys about this article. So let's start. So first is I have no financial disclosures at all. And what are our objectives is we're going to kind of review what the questions of the systemic review was, what the definitions of the terms, and specifically about the efficacy, effectiveness, and then what they meant by the primary, secondary, and tertiary preventions, as well as what the term spinal manipulation, spinal mobilization, and spinal traction was used specifically for the systemic review. Also what their search terms, as well as the inclusion and exclusion criteria and their process, as well as the results, and then what we'll discuss the limitations and bias, as well as the concerns that this systemic review has. So first, what were the questions for the Global Summit? So they had 2 research questions, was the focus pretty much for this article. So they compared to sham or placebo interventions, is spinal manipulation, mobilization, or spinal traction efficacious for the prevention or management of non-musculoskeletal disorders was the first question. And then the second question was compared to other interventions, which could be sham when delivered in a pragmatic plan of management, or it could be also no intervention, is manipulation, spinal mobilization, or spinal traction effective in the prevention or management of the non-musculoskeletal disorders. So diving into the definitions. So efficacy is the performance of an intervention under ideal or controlled circumstances. If you see any numbers, by the way, on the PowerPoint, they are referencing the references at the end of this PowerPoint. So 1 would be the global. It would be the actual study itself that we're talking about, the systemic review. And then 2 is actually a website I found. It's, I think, at NIH, if I remember correctly off the references, is what they also agree with that definition. And then what they were saying for the systemic review, that the preferred design was a random controlled trial using sham or placebo to compare. For effectiveness, the definition again was the performance under real world circumstances, and real world is in quotes because it was also in quotes in the article as well. And again, the preferred design was a random controlled trial where new treatment was compared to other interventions, including sham. For the review, the random controlled trials as an effective trial if spinal manipulation treatment was part of management regardless of comparison group. So they were specifically looking at spinal manipulation treatment. So what does primary prevention, secondary prevention, and tertiary prevention mean? Again, this is from another source as well. They use these definitions as well as another source. So primary prevention is intervening to prevent disease or injury from ever occurring. Secondary prevention is intervening to cure or reduce the impact of disease or injury almost occurred. And then a tertiary prevention is intervening to improve the impact of persistent illness or injury that has lasting effects. Any questions so far? I don't see everybody, but I'm not seeing any hands waving at me. So
Nope, no questions yet, ma'am.
okay. So specifically going through spinal manipulation, definitions about spinal manipulation, spinal mobilization, spinal traction, and then what spinal manipulative therapy, which is in the title of the systemic review. So spinal manipulation is manual therapy to the spine involving high velocity, low amplitude, otherwise known as HVLA thrust for DOs in the room, and an impulse thrust applied either done manually or using a mechanical device. For spinal mobilization, they considered that manual treatment to the spine that incorporates movements within a joint's passive range of motion, either done manually or using a mechanical device again. And then spinal traction was manual or mechanical assisted of intermittent or continuous distractive force. And then specifically for the systemic review, they labeled spinal manipulative therapy as spinal manipulation, spinal mobilization, and spinal traction were all collectively known as spinal manipulative therapy for the systemic review. Okay, so all three of those definitions was what they were using for looking for articles, trials. So search terms were rather vague. So the only mention really was saying they were using subject headings specific to each database, mesh, for example, in Medline, and free text words relevant to manipulation, manual therapy, effectiveness, prevention, treatment, and non-musculoskeletal disorder. They didn't actually list all the non-musculoskeletal disorders that they looked for specifically, which I thought was rather odd when they were looking for all non-musculoskeletal disorders. That's a lot. That's very open to interpretation. So I found it rather odd that, but I was going to open that to discussion. That is one of the things I wanted to talk about. So what they considered inclusion criteria was obviously written in English and then was published from the beginning that they could find from the database inception to May 15th of 2019 in a peer-reviewed journal. They investigated non-musculoskeletal disorders and then any random control trial that investigated the efficacy or effectiveness of spinal manipulation, mobilization, or traction, study population of all ages, and then included at least one outcome that is specific to a non-musculoskeletal disorder under investigation and measured at the patient level. And then also they wanted to make sure that each group number of randomized participants per group were greater than or equal to 20. As for exclusion criteria, they excluded pretty much anything that was not really a random control trial. So no guidelines, letters, editorials, commentaries, unpublished manuscripts, dissertations, government reports, books or book chapters, conference proceedings, meeting abstracts, lectures, or and then anything that addressed the consensus development statements or guideline statements. Also, any cadaveric or animal studies, as well as non-clinical studies that aimed at only to understand the physiological effects of spinal manipulation. And then they also excluded any pilot studies aimed at demonstrating the feasibility of conducting a full random control trial. And then they also included studies in which they couldn't isolate spinal manipulation, mobilization, or traction. For example, what they meant by that is studies where spinal manipulation was included in a multimodal program of care. And we'll go back to that in a little bit on that last point. For the process, it's pretty much they had 4 pairs of reviewers independently screening all potential eligible articles in the 3 phases. In the first phase, they just looked at titles and abstracts and separated them into relevant, possibly relevant, or irrelevant. And then phase 2, they looked at the full text again of the relevant articles only to see if their final determination of eligibility. And then the phase 3 were studies that were judged. Then they separated them into whether they were primary, secondary, tertiary groups as well, if they fit any of those. Risk for bias, they used the SIGN criteria, which is the Scottish Intercollegiate Guidelines Network criterion. Sorry, 1 second. And then also they used a SWIM criteria, which was a synthesis without meta-analysis and systemic reviews. It's 2 criteria to determine whether if it was effective or efficacious. So 1 would be study to provide evidence that the null hypothesis was unlikely hypothesis for the group, and then also if the difference was found, whether the difference was clinically important. So they restricted the random control trials with acceptable high methodological quality because low unacceptable quality yielded biased estimates. So how they determined what was considered high versus low quality was what was a method of randomization, did they conceal the treatment allocation, was there successful blinding of participants, and also blinding of outcome if there was good blinding of outcome assessors as well as investigators. And then as for the results, so this is actually from the study itself. Sorry, I'm just going to move the top out of the way. So what they found for identification, there was about 4,997 in the data search. Database search, they had 3,874 which were duplicates, so they were removed. And then that was what was left after duplicates were removed. So they went through 3,874. They excluded during phase 1 3,655, and then it went down to only 219 articles. Of the 219, I found it was rather interesting. I circled it that the duplicates, they found more duplicates, which I thought was rather odd, since the first screen was supposed to, before the first screen, they were supposed to have done that anyway. They found another 50, which is kind of a large amount out of the 219. That is almost a quarter of the articles were duplicates. And then they had a few that were different things. Ineligible study population probably being too small under the group. Ineligible sample size, different type of publication, maybe on not peer-reviewed articles. So they got down to 32. Out of the 32, they excluded another 16. And so they were down to 16 that they actually looked at. And then they split those into primary prevention, secondary prevention, and tertiary. There was none in the primary prevention. They had, all 16 hit secondary prevention, and then of those 16, 6 also did tertiary. However, of those 16, 9 were excluded out due to being low quality, again, going back to what they considered low quality versus high quality, as well, or unacceptable. So they got down to just 6, and of the 6, they were secondary and tertiary again. So we're going to go into each one, since there was only 6 articles in the systemic review. So of the first one they did was of the balance study on childhood asthma. Of that, they had 91 children in this study specifically, there was 91 children physician diagnosed mild to moderate asthma confirmed by lung function tests. Both groups received usual medical care and then treatment of either the treatment arm or the control arm 3 times weekly for 4 weeks and 2 times weekly for 4 weeks and then 1 time weekly for 8. Of the treatment arm, they basically split the 91 kids pretty evenly between 45 and 46. 45 participants received spinal manipulative therapy of HVLA and gentle soft tissue. And then the control arm had non-directional, low amplitude, low velocity impulse to gluteal, scapula, and external occipital protuberance, but also had soft tissue massage and gentle palpation to the spine, paraspinal muscles, and shoulders. And when they talked about the scapulae, what they, when looking at the actual study, they described it as just medial to the scapula border. And then the gluteals was just at the gluteals. And then they found no difference between control arm and control arm and treatment arm for peak expiratory volume, as well as their secondary outcomes as well, which were quite a bit. So that was the childhood asthma one where there was no difference between the arms. And we'll discuss some limitations about the sham arms of each of these. The next one was the infantile colic that they found, an article, and this was done in, I'm not going to be able to pronounce that last name, in 2001. It was basically 100 infants who had infantile colic defined as greater than or equal to 3 hours of crying per day as 3 days per week for at least 3 weeks. Both groups had counseling support on feeding, baby care, and family interactions and treatment for 3 sessions with intervals of 2 to 5 days over 8 days. The treatment arm was 46 participants versus control arm to 40, and pretty much the treatment arm was the spinal manipulative therapy and mobilization determined by treating chiropractor, dysfunctional articulations manipulated and mobilized using light fingertip pressure. But the control arm was just basically the nurse holding the baby for 10 minutes after partially undressing them. That would be similar in the treatment infant, and both basically the nurse would bring back the patient and from the parents. So the parents were not in the room for the patient, for the infant getting treated. So the parents would only see them leave, and either the nurse took them to get treated in the treatment arm or kept them in the control arm and just undressed them so that when they returned to their parents, they looked the same, whether they were in one arm or the other. And again, they showed no difference between the improvement of crying time. For hypertension, there were 2 studies, the GORTS one in 2016, which had 51 adults. And that's how on the screen shows the hypertension was defined as systolic blood pressure of 135 to 159 or diastolic between 85 to 99, and whether or not they had a C1 or C2 misalignment. The treatment arm had 24 participants, and the control arm had 27. In the treatment arm, toggle recoil with HVLA delivered to C1 or C2, and then they had 2 sessions per week over 6 weeks. So toggle recoil is a special table where basically you place, it drops 1 centimeter when a thrust is administered. So basically the patient's head is lying on there, and then when the thrust occurs, there's a drop in the toil. So it assists the HVLA that it's occurring. So it's an assist table. For the sham, the patients are still in that table, but how the provider holds their head is slightly different. They basically place the patient's head on their forearm. And so instead of, there is no thrust delivered. So what they do is, so that the patient thinks they're getting treatment, the toggle is activated by the provider pushing down on the board as if the thrust is occurring, but it's not occurring. So what they did was simulate a placebo in the sense of triggering the table to go off, but not having thrust occur. So to mimic it. That was our sham. And again, they only did it one session and then came back 4 to 8 visits at random intervals over the 6 weeks versus the 2 sessions per week in the treatment arm. And they didn't show any difference in blood pressure in either arm. For the ward hypertension study, there was 50 patients, 50 adults, and they had to have proof of high blood pressure, either being on medication or the initial blood pressure reading was over 140/90. Both groups were just treated in one session, and patients did not stop blood pressure medication. So 25 participants in each arm. For this one, they had supine upper thoracic spinal mobilization therapy to T1 to 4 with HVLA thrust of upper body of the chiropractor. So basically that follows in traditional, we usually in DO world, it's called Kirksville crunch. It literally, the description is exactly how we would describe it. And so, and then control arm showed that what the chiropractors would do was just to have the patients, like the arms are crossed like so in HVLA of the upper thoracics. So they would just uncross their arms as a control arm. They would fold their arms and then unfold them again. So no thrust was delivered. And then again, didn't show any difference between the two groups. The next study for the next non-muscular condition was primary dysmenorrhea, which was by Hondras in 1999. There was 138 female adults between the age of 18 and 45 that were diagnosed with primary dysmenorrhea. Both groups were treated on day 1 of cycles 2, 3, and 4, and then prophylactic treatment of 3 visits took place during the 7 days before cycles 3 and 4. The treatment arm had, both arms had 69 participants. The treatment arm got HVLA at a higher thrust force at 750 newtons to all clinical relevant levels from T10 to L5 and SI joints, versus the control arm was the low force mimic of HVLA between 200 to 400 newtons to L2 to L3 only. And they didn't find any difference between the groups as well. There was one interesting thing that I found while I was reading through and then went back and read this article. In the systemic review, they actually described the treatment incorrectly. The correct treatment is of when they did them is written correctly here, but that comes directly from the study. I found that was interesting in the systemic review. They had an error like that. Migraines was the next thing. There was actually two. So I put, I think the second one on here was the protocol as well, because they went back to explain what the protocol is. And so participants were 104 patients, adults again, and diagnosed according to the guidelines as well within and having more than a 1 migraine attack per month. They actually had 3 treatment arms. They had a treatment, a sham versus control. Each group had 12 sessions lasting 15 minutes, so each over 3 months. The treatment arm was 34 participants. The sham arm had 34 participants, but the control only had 29. The 34 participants, they talked about a specific contact HVLA short level spinal manipulative treatment. And then the sham arm had a sham one, which they talked about as a broad, non-specific contact, low velocity, low amplitude sham push maneuver. For the control arm, they just used pharmacological management. They found that migraine days were decreased, reduced within all groups from baseline to post-treatment, but the control group returned to baseline at 3, 6, and 12 months follow-up, while the effect continued for sham and treatment. the systemic review found that significant difference in mean change in migraine days favored the sham treatments. The article itself did not talk about that in the discussion, but the systemic review talked about that specifically, and I was unclear how they got to that specific statement when the actual study did not discuss that. So I would leave that open to the floor when we get to discussion. I'd be very curious to see if anybody else understood how they got there. So from some of the limitations for this, I found was that they included osteopaths into the initial discussion of the global summit, but then there were no osteopathic authors or osteopathic summit participants. They were all chiropractors or related to the insurance company or to insurance company. They also did not include any osteopathic studies at all. They actually had no spinal mobilization and no spinal traction studies were included. Even though their definition included those terms, they only had HVLA studies, which was interesting that they decided to name it that. They also didn't include any studies that included rib mobilization. They excluded those. They also excluded studies, including other modalities besides HVLA to the spine only, which is pretty much what I found with those. And that some of the shams were also treatment areas. Specifically, I think 3 of the 4 studies had what I would consider treatment shams. And then some studies included mixing spinal mobilization as well as the spinal therapy, and even though there were studies excluded that were multimodal. So the one specific one I had underlined, I think it was this one on infantile colic, where they said dysfunctional articulations manipulated and mobilized. So that was one that I would consider a multimodal, but they had included it anyway while excluding others that had the same. And they also excluded a random control study that did demonstrate spinal mobilization or traction, but not spinal manipulation. So there was a study on migraines that was GUINEY. It's actually in the references that I've listed later. GUINEY, sorry, GUINEY. That is the main author. That actually showed improvement with mobilization, spinal mobilization, that did show improvement with migraines in the treatment arm. And that has been cited multiple times in multiple follow-up studies, but they did not include that one, and that was an osteopathic study. My concerns for this was, will spinal manipulative therapy, the broad term that they use, now be extended to all manual therapy? And the systemic review only really included studies with HVLA. That was one of my concerns. And then will this be used to dissuade use of manual therapy for conditions, for non-musculoskeletal conditions as well? When, again, we probably do need more research, as well as the fact that the studies that showed multimodal were excluded, that were actually beneficial. So that's where I would have wanted to open up. I'm sure I didn't catch all of the I was looking really quickly to see if I could find any studies, and I could think of multiple that not necessarily had HVLA, but did have multiple improvement, especially for like pneumonia and asthma, that actually had the rib mobilization and rib raising, which would not be considered HVLA, but would be considered direct treatment and mobilization. So I'm going to open up the floor to questions or discussion, really.
Okay, so if you have any questions, you're more than welcome to put them in the chat or raise your hand, and we will ask you to unmute your microphone. And if you feel comfortable, you can turn your camera on as well. Dr. Nizio, we have a couple of questions and comments so far just in the chat. So I'll read the comment, and then you can just kind of chime in as you feel necessary. So one says, it seems weird that the baby study was looking at mobilizations when babies are all fluid and membranes except for OA for the most part.
Very true. I'm not going to disagree with that.
And then it says, another one says, 45 years ago, I was taught that the second left rib was the asthma reflex. Palpation / soft tissue of the medial scapular border might have overlapped that.
Exactly. And that was one of my concerns as well. I was actually thinking that the way they were talking about that medial scapular border, I was like, that it was all along the rib angles. So of all the ribs along that area. So if they were creating a low amplitude thrust or push, I would still think of that as a springing technique or articulation of the ribs, because right at the rib angles. So that's why I was saying the shams, some of the shams had a treatment component that I would consider a different form of mobilization. So it would not be, I wouldn't consider that a high quality study because the sham is not really being very specific enough away from what we consider treatment. Yes, I agree.
Thank you.
Would be the short answer to that.
So we have a question. It says, does CMS currently acknowledge OMT for anything other than MSK complaints? And I apologize, I don't know what that means.
So they're talking about Centers for Medicare and Medicaid.
Okay.
So from what I can tell, OMT is allowed, period. I don't think there was, I leave that to ask other physicians in the group as well, that I'm aware of. Medicare doesn't really dissuade the use of OMT at all. We are allowed to use it if there's a somatic dysfunction, right? If the patient has a somatic dysfunction, that allows us to bill for OMT. So if someone comes in and they're having like upper respiratory, let's say, or sinus, the classic one is sinus infection, right? Someone comes in and you think they have a sinus infection and you find a lot of dysfunction in the upper cervicals and the head, and you're just doing sinus effleurage as well as treating the OA and the upper cervicals, opening up the thoracic duct, so opening up the thoracic outlet. That'll be should be, even though you have sinus infection as possibly, or upper respiratory infection as your primary diagnosis, you found somatic dysfunction. So from what I know, CMS will pay for, if you have a somatic dysfunction, they'll pay for it and you're billing it appropriately. Especially done in conjunction. I'm going to leave it open to other physicians if they found anything different, but from what my understanding is, it's not connected like that.
That is currently all the questions we have in the chat. Does anybody have any questions they'd like to ask via microphone or video?
I see Amy, hands up, and Dr. Degenhart. I don't know, Amy Dean, I'm not sure if you are.
Oh, there you are. I lost her on the screen. Okay. All right, Dr. Dean, and then I'll get to you, Dr. Degenhart.
I don't know if anybody else feels this way, but I really feel like it's a call to action for hospital OMM research, because and I'm very biased because that's what I do, but I see the sickest patients benefiting the most, which is COPD, pneumonia, little babies with latch disorders or in the NICU. And it's like, when you really mobilize those chronic dysfunctions, and I know in our field, we're always talking about these acute things to treat, but it's the really stuck chronic upper thoracic vertebrae that are contributing to like COPD exacerbations. And, for this paper to come out and say, well, there's no connection, to me is just kind of a call to action to get something out there in the published literature that says, well, Still was right. It actually does matter, but maybe I'm too fired up about it and I don't, but that's the way I see it anyway. And it seems like the sicker the patient, the more they benefit from spinal manipulation and OMM, but thanks. Thanks for
No, actually, Amy, Dr. Dean, I think I agree with you. Taking care of COVID patients currently, just getting the ribs moving, and I'm doing, we're consulted for OMT. Currently I have like 4 patients out of our 10 patients in ICU that we're doing OMT on, and they have COVID, and so we're currently working, just treating them and trying to see if we can get any of that motion and get their lung function working better for the medicine team, right? So that hopefully we can get them off any of the CPAP.
Right. And I haven't treated acute patients for COVID, but I have seen patients in rehab, and just getting their diaphragm moving in their ribs, they start to breathe better. Their energy levels start to come back. They get through acute rehab quicker. So yeah, I totally agree with what you're saying too.
And then that was one of the things and Dr. Degenhardt's on here. So, but the MOPSI study too, they excluded the MOPSI study, and that one we know, we're like, what? Why?
Yeah, exactly. It's crazy. Sacrilegious.
So Dr. Degenhardt, I think, was next, and then I think Dr. Johnson.
Yes.
Yeah, I'm not sure, looking at their exclusion criteria, what the MOPSI study would have done or would not have done to have met their criteria. So that is kind of interesting for sure.
Mm-hmm.
I think part of the challenges I see, so first of all, I give them credit for having put forth, this level of effort to evaluate their model. But their model is definitely different than our model. I mean, whether it is their model, but they are trying to adapt it for a scientific model where you say you just do one thing, for one problem, without recognizing that in this area, every person's complex of problems can be unique. And so one of the things we did in the MOPSI study was establish what we considered was a standard protocol, but built within that the ability to do things that were unique for the needs of that individualized patient, which is clearly an osteopathic, perspective, which is untested, other than perhaps, and certainly the MOPSI study would be probably the largest study looking at a non-musculoskeletal condition.
Mm-hmm.
So I agree with you, Amy, that here we are as a network. We exist because we want to do research in this area. It should be a call to action to us individually, certainly to us as a profession, and to the model that we've been trained under, because I don't see that this literature really represents an osteopathic approach to non-musculoskeletal diseases.
Mm-hmm.
Jane, did you want to jump in at all?
Yeah, one of the things, as a statistician, I can, I'm not certain about all the implications of, just spinal versus ribs and stuff like that. But I've been around enough to know that osteopathy doesn't treat just the spine.
Mm-hmm.
But one of my concerns about the study, and I'd be interested in finding out your perspective on that, is the mixture, making a conclusion about non-musculoskeletal disorders when you have such heterogeneity of non-musculoskeletal disorders. So I'd be interested in your views on that.
So yeah, so I mean, in osteopathic medicine, we have the 5 models, right? And so depending on which angle, where are we looking at, where are we looking at, which model are you looking at? Are you looking at the biomechanical model? Are you looking at the circulatory model? Are you looking at the lymph model? Are you looking at the oh gosh, a behavioral model, right? And so there's different models we can look at, and sometimes we merge a couple of those together, just because we find, you know, there's a behavioral model and there's biomechanical thing going on, meaning like they're having low upper back pain, right? And but they're also depressed or anxious, and so they're carrying a lot of their anxiety in their back. So anxiety is a non-musculoskeletal disorder, right? And so, but how many of our patients have upper thoracic or low back pain, and they somatize it, right? They make their worry, their anxiety become musculoskeletal. And so, depending on which model you use, so I find it like you said, they used such a broad-based word, and then didn't like focus down into, did they want it across different things? Like, I don't know. They had so many studies, but I still feel like they excluded. There were probably even more studies that were not included in that search. Because I'm like, 4,000, I'm pretty sure there's probably more than that, but I don't know. I was like, I'm not going to do it myself. No. Sorry, guys. I was going to, but I was like, no, I'm going to do the migraine one because I knew there was a migraine one that was not popping in, and I found it. That was like Winnie, and then Mopsy. I was like, why didn't they include that? There was another asthma study too, and I was like, why? So I have them in the references because I couldn't understand why they excluded them. But
Thank you, Dr. Nizio.
no problem. I'll leave it open to the floor if there's anyone else that can answer that question for me.
Yep, I think Dr. Brooks has a question.
Okay.
We also have a comment or a question in the chat too. They'll ask after Dr. Brooks is finished.
Okay.
I have more of a comment. I agree with a couple others that this is certainly a call to action. And more broadly, this is a great example of, and you did a wonderful job, Jessica. I haven't met you, but you did a great job of beginning to critique this paper. You know, systematic reviews are at the top of the evidence pyramid, and there's a tendency to just, you know, take them as virtually God's truth. And they're profoundly human endeavors. And this is a great example of a review that's, the conclusions are almost necessitated by the assumptions and biases that it starts out with. And so for those of you who are in academia, you should use this paper as a teaching tool. I would encourage you to use it as a teaching tool of the problems with systematic reviews and the need to be very critical thinkers about them. Just because it's supposedly at the top of the evidence pyramid, you know, doesn't make it the truth, the whole truth, and nothing but the truth by any stretch of the imagination. We've been talking about how this was so chiropractically biased, and that's just one of the many other biases and assumptions that have gone into this. So I would encourage you to write a letter to the editor, whoever published this, and, you know, point out the flaws in this study.
Was thinking of doing that actually after reading it, because I was very upset while reading it because I found that the bias, they're saying there was no bias, but there's a lot of bias in this. Also, do we have anyone that's outside from the United States in here?
We do. Dr. Marcucci, he's raising his hand right now.
Okay. Is he from Italy? Or is he from Canada?
I believe he's from Italy, but I can't remember off the top of my head.
Okay. Thank you, Dr. So
Luxembourg.
Luxembourg. Okay.
Sorry.
So I found out, I double checked. I had heard that the Canadian osteopaths are not allowed to do HVLA as well. We were at Founders Day, and we had a presenter that was Canadian osteopath, and she had mentioned that in passing. And then I double checked when I was reading this, because this comes from the Canadian side of things. And so I found that rather interesting that they included the osteopaths when majority of them are Canadian, and the osteopaths in Canada are not allowed to do HVLA. So I found that rather interesting and included into the bias. Thank you, Dr. Brooks, because I agree. There's major bias.
That's so interesting, Dr. Nizio. I'm going to ask Dr. Degenhart to unmute. He has a question or comment. And also
And-
he addressed the comment in the chat too.
Let's see that.
Well, yeah. So and after me, Dr. Marcucci, he has been trying to say
Oh.
something. We'll pass the mic on to him after me.
I'm so sorry.
I think Dr. Nizio, I think you're exactly right in your last comment about why MOPSI was excluded was because there were aspects of our techniques that did not fall within their criteria of spinal manipulation, spinal mobilization, or traction. I mean, we had fluid techniques, we had, other myofascial release types of things. So our protocol was adequate for them to exclude it. And so now with that discussion, I do think they did follow their rubric, but once again, that significantly limits how their outcomes can be generalized. Dr. Marcucci.
Oh, I think you're still muted, sir.
Now, do you
There
hear
you
me?
go. Yep.
Okay, thank you. Dr. Degenhart, I'm absolutely agree with your comment. And what here in this systematic review, we see how we have to point out osteopathic research, because otherwise we will be in a group of therapies, manual therapies included, and our specificity will disappear. And if who is betting that in 50 years someone will talk about osteopathic medicine if we don't react now to put the founding of the osteopathic research on a way that it is acceptable from our colleagues, physicians, and it is also acceptable from the older community of the scientific community on the world, and that they know what is osteopathic medicine, and they cannot anymore match or mix our techniques in their techniques and giving stracciatella techniques to the eyes and saying that their techniques, and if people then looks in, for example, physical therapists are allowed to do spinal manipulation, and we are also allowed as osteopath to do it, but that's not the specificity of the osteopathic medicine. But in the head of the people, what I see in my patients, among my patients, or when I speak with other people who are not my patients, they think that osteopathic medicine is always associated with spinal manipulation. And therefore, I think we have a lack to fulfill and to make the communication more clearer. I hope that next year during the conference that can be emerge, and also not only showing results, because we do always osteopathic results. I applied these techniques, one techniques, and I have a result. But if we could go in the physiology and physiopathology and see what is produced on a blood level from substances that can be evaluated, then we would have more, I think, better results that we can also do a prognosis saying using these kind of techniques, you can have such anti-inflammatory cytokine produced to fight inflammation. And so long we will do techniques, I said, produce. I am sometimes upset of osteopathic congresses because they are showed. They are very. The MOPSET study was unique, which take my focus, my attention so strongly, because they showed on a clinical way what we can do, and they measured the blood test. The blood to see what was produced. But when you see, Brian, you remember in 2019, all the osteopathic studies were shown on the Congress on the VOD in Germany. That's always Mr. X is presenting techniques, and now we see what the patient is going better. But who says not, if I put some Olivia oil here on the temporal, the patient, and I speak very well to the patients, that the patients will feel better.
Thank you, Dr. Marcucci.
I know. I have so much to talk to. I'm sorry. I will cut.
You're fine.
That's my Italian way. Sorry. Scusate, ragazzi.
You're fine. We do have one more question in the chat.
But congratulations, Dr. Nizio. It was really, that's, and as it was proposed to you to do a letter to the editor to point out the bias of the study, that would be great.
I'll probably
Thank
end
you.
up sending it to a few of you that are on here to read through if you would like to add anything. Because I think it'll be much more forceful if it's more than just
If
me.
you need my help, I would be pleased to help you.
Absolutely.
Thank you so much. Dr. Degenhart, this question is actually for you in the chat. It says, how do we move beyond that, Dr. Degenhart, beyond case studies? Where do we begin? I believe this refers to the conversation in the chat. Sometimes it seems overwhelming when working with the students and residents on research projects that are more than just case reports.
Yeah, so I think the answer is different if we're in an academic setting versus if we're in private practice. And I would like to make comments on both of those. So first of all, if we're in a private practice, I mean, this is exactly why practice-based research networks exist, because we do not have the ability in private practice to really contribute to the scientific process without support. I've been there. I know what it's like, and it's just, and that's why we, along with about another 180 practice-based research networks within the United States, exist. The issue is it requires participation. When we launch a study, define how do you integrate that in your practice. Nobody else can do that. And I know that our recurrent theme, a response to that, is that there's not enough time, just like Jeff is telling me. So so that's my comment from the practice side. In the academic side, I think the problem is that we try to put the burden on the individual student to do everything in its fullest within their lifetime, within their own experience as a resident. The bottom line is we as resident directors and trainers need to help people establish a longitudinal ongoing study that crosses not just with a single resident, but with residents over time. Sustaining a research question, sustaining data collection in a systematic way is what science is all about. And so if you are in that academic scenario, establishing a way of continuing seeing the research beyond the individual resident, but within the residency over time, I think that can make a big difference.
Thank you, Dr. Degenhart. We don't have any more questions in the chat. Does anybody have any other questions that they'd like to pose? We have about 5 minutes left. Questions or comments, Dr. Brooks?
Well, I obviously haven't read the 5 or 6 studies that were cited, but my question is, how thoroughly were the diagnostic techniques described, and whether there was any documentation that what we would call somatic dysfunction, I guess the chiropractors call it misalignment, actually improved as a result of the intervention. In the absence of that kind of detail, it's basically all just a shot in the dark. These are basically just random techniques being used, and So was any of that included in any of the studies?
Yes. So, sorry, hold on one second. Let me pull up, because I had put notes for myself specifically. Yes. So they described the techniques specifically on the spinal manipulations of where their hand placement and what the direction they were doing as well. And then they did not describe soft tissue. They will just say gentle soft tissue. Now, when I think of soft tissue, I think of just perpendicular traction. So I was assuming that, but the one they did describe was the toggle recoil is actually described in the paper for that hypertension study. And then also the sham was also described. They actually had pictures of it.
Yeah. So, but my question is, did they detail that? So
if it was improved or not?
Yeah, we've
No,
all
I did not see
experienced
that anywhere in any of the studies.
Yeah, so that's a big challenge for all manual practicing professions, because you claim you're doing something, you got to document that the diagnostic phenomena that you're addressing actually had changed. In the absence of that, why would you even begin to think it correlates with any other condition, whether it's pain or asthma or whatever? You got to show that the musculoskeletal physiology changed in response to the treatment.
Thank you so much, Dr. Brooks. I just want to say in our 2 minutes that we have left, next month is our network update on January 21st, and you guys will be getting an invitation to register for that shortly. Dr. Dagenhart, did you have any final comments, thoughts, well wishes for anybody?
There we go. Yeah, so I just want to make mention that the DO-Touch.NET will be having their annual meeting in March. And Jane or Sarah, can you remind everyone of the date?
Yeah, it's March 23rd, and registration is open. And you guys should have received your email invitation today, either last night or today.
Okay, and that's where we're going to certainly expand on how we can perform rigorous research within the network and have some really explicit directions that we've been working on over the year at that meeting. That is a Wednesday morning in the United States. It is a pre-convention or convocation program. And we are having this as a hybrid meeting, so people can join us from around the world, although it will be held live, as far as we know, in Florida. So please get that on your calendar. Please register for that. We'd like to really engage many more members as we look at our next round and directions for research. So once again, on behalf of everyone at DO-Touch.NET, at the AT Still Research Institute that sponsors our network, I want to wish everybody just, first of all, thank you for being here. Thank you, Dr. Nizio, for doing an excellent job in presenting that study. There is always opportunities for people to get involved. Let us know what you're interested in, and it may not be tomorrow, but it will be, it will happen. We are getting a lot of people interested in leading this type of program and so forth. So please let us know if you have research ideas. Let us know. I do think the one thing that became apparent in our group is that if we see a recently published study that we have concerns about, that's when we need to be writing our letters to the editor, not 2-3 years after it has been in print. And so that having those things become that we become aware of that, and maybe we have to make some adjustments in our programming so we can have a meeting that will help us to really delineate a response from our network on that. I think that would be really helpful. So we hope that all of you have a very peaceful, restful, nutritive remainder of your year as you all engage in the holiday of this time. And we are looking forward to what 2022 has to offer. We'd love to say that we would have a lot of hope that the pandemic was going in the way that we want, but that's certainly not exactly what we're seeing at this time. But what we do know in the human race is we are a surviving species. We find ways to survive, and we will continue to do that. And by participating in these meetings, I think it just really helps us to, keep our community together. So thank you so much. Have a great holiday, and we will see you next year.
Thank you.